Hello, this is Emily Peters. I am recording for part of the hematologic system issues, and we will be focusing on sickle cell disease. All right, so this should all be reviewed for you, the functions of the hematologic system, and I'm not going to go into our different types of blood cells and things that we have in our system. What you need to think about when the functions of the hematologic system, besides just looking at labs and different abnormal readings for those, is things that we may see on our assessment that will tell us if there's issues. So things like fatigue or malaise, the pallor or the color of their skin. Do they have unusual bruising, bleeding that's not able to be stopped, or issues that way? I'm sure there's more that I haven't listed. That's just a quick overview. All right, once again, this should be review. So different other components of that assessment besides our CBC is looking at that historical data, things in that kid's background. Were they born prematurely? Do they have any diagnoses that could be affecting their hematologic system? Anything the parents that have seen that's abnormal, growth, development, signs of infection. That all also goes in with that physical assessment. Looking at family history of disease processes like anemias. Assessing the child's energy and activity level, and has there been a drastic change in it? The growth patterns, are they growing appropriately? Are we seeing just a recent change, or has it consistently been the way that they are representing or presenting right now? All right, so this is sickle cell disease. This is a disorder where the red blood cells do not carry the normal amount of hemoglobin, or the red blood cells shapes themselves are not normal. Keep this picture in mind because it's a pretty good representation of some abnormal and normal cells. All right, so sickle cell anemia is a hereditary hemoglobinopathy. It typically is seen in African Americans, but it can be seen in other races. We only see it about 1 every 375 infants born in the United States. 1 in 12 has a sickle cell trait versus having the disease itself. We do sometimes see it in Mediterraneans, and like I said, some other races like Indians, Arabians, people from South America, places along those lines. This slide has been quite intriguing to me. Several years ago, a student brought this information up to me, and I was unaware of it. So the cause of sickle cell was a mutation in Africa, or areas of the world where malaria is common. This trait developed because by having these abnormal cells, this gave these people a survival advantage over those that did not have it when malaria is around. So it is a protective abnormality that these patients developed. One other thing to think about is sickle cell is an autosomal recessive disorder, meaning that 1 in 12 African Americans has the trait or is a carrier of the disease. for a child to have the disease, both parents have to at least be carriers. Now, the chances of the families having kids that actually have disease will go up if one or both of the parents actually have the disease versus being a carrier. All right, so some pathophys of sickle cell anemia. So, babies. And I've talked about this a little bit earlier this semester, but definitely in Care the Growing Family, is babies are born with, and while they're in utero, they have fetal hemoglobin. And after they're born, the majority, pretty much all of their red blood cells or their body is composed of this fetal hemoglobin. And that rapidly depletes over their life. Once they hit about 4 months to 6 months, then you see a very rapid depletion of this, and that's when that adult hemoglobin really starts to vamp up. They don't have a lot of adult hemoglobin before that first 4 months of life. They might have a little bit here and there. Okay, so one thing to think about when we're looking at our hemoglobin is their lifespan. Fetal hemoglobin only lives approximately 90 days, okay? Whereas an adult hemoglobin lives around 120 days. Okay, that makes a difference too. The fact that these babies and young children have this fetal hemoglobin in their body is actually a protective agent for them, and we may not see the sickle cell issues until they start getting more of that adult hemoglobin. Okay, so what happens? They have partial or complete replacement of that normal adult hemoglobin. And as that normal adult hemoglobin is producing and dying off, it is replaced by this sickled hemoglobin or hemoglobin S. Okay, remember that picture we saw couple slides ago where we saw those nice round healthy hemoglobin, and then we saw, or red blood cells, and then we saw these abnormal S or C shaped cells. Those abnormal looking cells are the hemoglobin S. Okay, so we have nice healthy round cells, and then we have these abnormally shaped cells floating around in our system. What's that going to do? Are they going to float around easy? No. They are going to run into each other. They're going to get entangled with each other. They're going to adhere to each other. So they have an abnormal adhesion, entanglement, and enmeshing of those abnormal shaped shells with each other. And what does that lead to? Blockages in their especially the microcirculation, where you have those very tiny vessels. And what does that lead to? Vaso-occlusion. Okay, if I have vaso-occlusion or blockages in my microcirculation, what happens? Well, you don't get blood to the tissues. So if the blood in the tissues is not getting there, we're going to have some hypoxia. And then we're going to have some ischemia. And we may even have infarction and cellular death of those tissues. Okay? It can affect many organs of the body. Okay? You can have stasis enlargement, so the blood can't get out of the organs. You can have infarctions and ischemia and destruction of the organs or tissues of our body. Okay? So really a quick rehash of the pathophys. You end up with a partial or complete replacement of hemoglobin with abnormal hemoglobin S. And remember, we're not going to start seeing this until these babies start getting lots of that adult hemoglobin. Okay. Another thing to think about is as these red blood cells start taking these sickled are being produced in this sickled shape, this also means those cells have a shorter lifespan. So they don't live as long as the adult hemoglobin that we all have. Okay? So then they're sickled, they die faster, They also are rigid, which causes that obstruction to your blood flow, okay, which then leads to obstructions and engorgement of the tissues or the organs. And we have hypoxia. When we have hypoxia, what does our bodies do? Produce more red blood cells, which means we're going to produce more sickled cells, which leads to sickling. We will get back to that in a few slides. All right, this is just kind of, once again, reiterating what I've been talking about. So we can have large tissue infarctions because we're not getting a lot of that blood flow, especially through the microcirculation, to get to those tissues or the organs. Okay, one of the biggest organs affected is the spleen. Okay. All right. So some other things that we might see with where we might see issues with the effects of the sickle cell. These kids could end up with strokes. Of course, severe strokes could lead to death. We have lots of small blood cells in our eyes, so we can end up with retinopathy or blindness, or hemorrhages in our eyes. Our liver can enlarge and kidneys can have issues. We can have gallstones. We can have blood in the urine, necrosis of the hips, priapism, painful, abnormal erections if you're male, osteomyelitis, ulcers. Ulcers don't typically occur in the kids, but they could. And as you can see also from this table, you can kind of see a couple nice healthy red blood cells, and then you see those abnormal cells, and you can kind of see how when they're in that microcirculation, they're kind of getting entangled together. If not treated well, these kids could end up with long-term issues. All right, so a little prognosis with sickle cell. There's no cure right now. Now, there's some thought that doing a bone marrow transplant, where that's where some of our red blood cells are produced, right? That maybe that'll help cure it. But also you got to remember it's our body that's producing these abnormal cells. So there's also wonder, will that completely deplete our body's normal reactions to develop these abnormal cells? We want to do lots of supportive care to prevent the sickling episodes, which means that the prognosis will go up or their healthy life will go up. They do get a lot of bacterial infections, and therefore they can become immunocompromised easy. So another thing to kind of think about when these kids are sick is we need to protect them a little closer. Typically it's the infections that cause the death in these kids. Okay, so making sure that they're getting their immunizations and staying healthy. We do end up with strokes in these kids, and those strokes could lead to increased morbidity in these patients. So they may end up with developmental delays, cognitive impairments, things along those lines, especially if they're not treated well. So, a sickle cell crisis. I told you we talked about this in a few slides. So things that lead to your body to have a sickle cell crisis. Anything that basically increases your body's need for oxygen or alters the transport of oxygen. So, if my body isn't getting oxygen where it needs to go, our body tells us to do what? Produce more red blood cells, because more red blood cells should hopefully do what? Get more oxygen to the places that need it. That's all fine and dandy. But that also means we're going to produce more abnormal shaped red blood cells, or this hemoglobin S, which actually could make the situation worse. So a sickle cell crisis. So let's think of these things. Trauma. Trauma, our body produces more red blood cells and other cells to get to that area to heal and get some oxygen. Fever and infection, we're producing more cells to heal, including cells carrying oxygen. When you're active and or emotionally stressed, we're requiring more oxygen. We're breathing faster. Our needs are a little bit higher. What do? You produce more sickled hemoglobin. When we're dehydrated, what are we going to do? We're going to produce more red blood cells. And in fact, we may not produce more red blood cells, but because we have an increase in the blood viscosity, because we don't have a lot of that good fluid in our cells, that actually increases the likelihood of those cells to enmesh and get tangled. Okay? Your blood gets thick and viscous. And if it's thick and viscous, you're going to have a higher chance of those cells enmeshing. So really increased viscosity due to dehydration doesn't have anything to do with that oxygen need. Okay? Hypoxia. In general, you're hypoxic. What are you going to do? Produce more red blood cells. So things that can cause hypoxia: high altitude, poor pressure in airplanes, breathing fast because you're stressed, scared. You have vasoconstriction because you're hypothermic. Those can cause the cells to enmesh. Okay? So, people with sickle cell disease are followed closely with their doctors when they are traveling. They're supposed to get up and move a little bit more. They may have to take more indirect flights and have more breaks in the airplane versus taking long direct flights. Football players. There's lots of famous football players that have sickle cell disease. However, and they're followed well from their doctors, so that's why they're able to play these sports. They're kept well hydrated. Their accounts are followed closely, things like that. But if they were to play in places like Colorado, that could actually set them off into a crisis. So in fact, a lot of the times when these football players are actually slated to play like the Colorado Rockies, I think that's the football team, that those players would actually be benched and not play during those games. Okay, that's all due to protect them from having an issue. All right, so there's several different types of crises. Let's see. Other things that can lead to, or types of crises, So you have these acute exacerbations due to the poor blood flow or the need for oxygen. There's a few types. There's the vaso-occlusive. This is the most common, the thing that we're going to see, from my understanding, the most in the hospital. It's very painful. Okay, when you think about you're not getting blood to your body parts, you're getting a lot of pain. You're also going to have ischemia, infarctions, and fevers. Okay, tissue engorgement, because what's happening is you have blood pooling in those areas. Okay. We have the splenic sequestrian. This one is life-threatening. What ends up happening is the blood is not able to leave the spleen because that microcirculation is blocked off. And what happens? The blood just pools. It pools in the spleen until it gets larger and larger. You end up having hypovolemia because you're not having good blood flow through your body. You're going to have, and then your spleen also helps produce some of these red blood cells and things like that. You're going to be anemic because you don't have that hemoglobin floating around in your system. And then they're going to have shock because of the spleen becoming so enlarged and possibility of perfing and the hypovolemic shock that's going on. Okay. This would result in a splenectomy. And hopefully we catch that before we have a spleen that has perforated. We have an aplastic crisis. An aplastic crisis is when we don't have enough production of these red blood cells and then they're rapidly being destroyed. This can be due to a viral infection or lack of folic acid. So it may be common for these kids to get folic acid in their diet. You're going to see that anemia and that pallor. Okay. The one I don't have listed on here is the hyperhemolytic. It's kind of similar to the aplastic. The one thing that's different is the hyperhemolytic is producing the red blood cells normally. What is actually going on with this one is they're just having that fast destruction of the red blood cells. So they're producing just fine. They're just dying off really quick. They're going to be anemic. They're going to have some of that jaundice. And then they're going to have reticulocytosis, meaning they're reticking. They're producing red blood cells in a simplified term. So you may be wondering, well, how in the world do we know these kids have sickle cell? There's several different ways we can screen. We screen all babies with that newborn screen, okay? That newborn screen kind of tells us that there's some possibilities of something going on with your baby, right? Well, for certain things, it's just going to give us an indicator that they might have it or they might not. They may just be carriers. So that's the case with sickle cell. It's going to tell you that your baby could be a carrier or they may have it. But to find out if they actually have it, we have to do more testing. Okay? You can do the same with their cord blood. However, with the cord blood, it's still the same thing. It won't tell you if they're a carrier or have the disease. So we're going to see this abnormality when testing that child's cord blood, but then we're going to have to do further testing again to delineate, and I'm saying that wrong, I'm sorry, to say that this baby actually has the disease instead of a carrier. Okay? Sickle cell turbidity test is also that quick screening for kids over 6 months of age. Why is it a quicker screening? They could look at those cells. They're going to get a little bit more definitive things. But in infants, the best way to find out if they have sickle cell is just to go ahead and do the hemoglobin electrophoresis if we have an idea that this kid could have it. So let's say mom and dad are both carriers. They may go ahead and just say, let's do the hemoglobin electrophoresis. This is actually going to look at the fingerprinting proteins and say, yep, this kid has the proteins in their system that is positive for sickle cell disease. So in anybody under 6 months of age, hemoglobin electrophoresis is the best test to say, yes, you have the disease. Okay. Why don't we just do a CBC and look at those cells? Well, you may not have any adult hemoglobin until you're getting closer to 4 to 6 months of age. So just looking at the cells isn't going to tell you anything. Okay. So that's why we can't just look at those cells in kids under approximately 6 months of age. All right, so what do we do for managing sickle cell? Well, for one thing, we need to prevent those sickling phenomena. So make sure our kids are getting their immunizations. Making sure our kids are staying well hydrated. And remember, kids don't know when they're thirsty and they get dehydrated easier. So these parents need to make sure their kids are drinking frequently as well. Okay? We want to treat medical emergencies quickly. Now remember, if this kid has a cut, they're not going to bleed out and have tons of bleeding In fact, what could happen is they're going to clot off really quick. Because what's happening, the blood is getting into that microcirculation and we're producing more and more blood. And then eventually it's just going to clot off and have those cells enmeshed, and then we're going to have necrosis and tissue issues, okay, oxygenation issues. It's not going to be lots of bleeding profusely, okay, so they don't bleed out, okay. If they're sick, we might treat their infections a little bit more aggressively than a healthy child because we know that can cause them to have more sickling. It's possible that we would go ahead and do some prophylactic penicillin to help offset sepsis and different things, especially when they're 2 months to 5 years of age. Okay. Blood transfusions, we may give them more frequently. What's it going to do? It's going to get lots of healthy red blood cells and fluid into their system to help decrease the amount of ischemia. We can do an exchange transfusion, and I've mentioned this a few times, either in care or this class. When we take out so much of the patient's blood and replace it with donor blood or saline, and what's that going to do is dilute out those sickled cells. We're going to do good diet management. This kid needs to have a really healthy, high in folic acid and iron diet. We want to make sure they're staying really healthy and getting lots of nutrients that are going to help ward off infections and things like that. They get different medications depending on their situation, and your case study should have discussed at least one of them. And if we notice that they're having issues with their spleen, we may go ahead and do that splenectomy early. We're going to follow them closely to make sure they're not having any strokes or any signs of stroke. We may also want to make sure that they're meeting their milestones and monitoring their growth closely. Looking over that head-to-toe assessment, okay? Replacing electrolytes. They can have metabolic acidosis, so that's one of the reasons why we want to make sure we do good electrolyte replacements. So when we're doing their labs, make sure we're looking at their sodium, potassium, and all of those electrolytes. Pain is a very common issue with sickle cell anemia, and that could be kind of crippling to our patients. So we'll want to do a lot of pain management. Your focus questions talked about the ABCs of pain. Quite a few of you had at least the A, B, and C. Several of you had all of them or close to all of them. So analgesics might be used, Tylenol, Motrin, things like that. But the ABCs. A is we need to assess that patient's pain with the appropriate pain chart or pain scoring system. Okay, we're going to believe what that patient tells us their pain is. So that's the B, believe. Then C, we're going to look for the complications or the cause of their pain so that we can hopefully fix that. D is then we'll use drugs and distractions. We want to use both. Assess, believe, then intervene. Drugs, distractions. Then we'll do environmental changes. Okay? So drugs and distractions should hopefully work pretty fast. Then we're going to make those environmental changes. Turning the lights down, turning down music, reposition, changing the temperature if the patient is complaining, okay? Then we're gonna give them fluids, typically like a hypotonic fluid, maybe a D5W, a D5 with quarter NS, something along those lines to help rehydrate them, okay? One thing we don't always do to manage their pain is give them oxygen, or manage their sickle cell, is to give them oxygen. I know that sounds strange. Why wouldn't we give them oxygen? Well, oxygen can actually cause more production of red blood cells, which can cause sickling. It can also inhibit the production of healthy cells and things like that. So unless they're symptomatic, we may not give them oxygen. So even though their oxygen status is 90, but they're breathing fine, they're doing well, we won't throw oxygen on that child. If they're 88 and they're breathing well, not showing signs and symptoms of struggling, we may not give them oxygen. Now, if they're breathing rapidly, they're cyanotic, things like that, then of course we're going to give them oxygen. Okay? And promoting that healthy growth and development, making sure they're getting access to PT, OT, different things to help them develop normally, stay on task, not get behind in their daily lives, and make sure they go to school and have normal activities. They can be in gym, they can be in some sports. Not all of them should be playing football and doing things like that. Maybe some things that don't require as much oxygen need, but they can still be active. We don't want them sitting in front of a computer or a TV all the time. All right. Oops. All right, so this should be our last slide. Psychosocial needs. Helping them cope with their hospitalization. Helping the parents cope with a child that has a long-term disability. These kids can live to their 30s, their 40s. I believe the lifespan is getting longer and longer. Genetic counseling. Let's say the parents didn't know they were carriers. Giving them the genetic counseling and understanding of the chances of them continuing to have more kids with sickle cell disease. Then helping their kids realize if they are carriers or if they have the disease process so they can make those long-term ideas. Helping the parents cope because they may not know anything about the disease process. Finances. It's expensive. These kids can be in and out of the hospitals. They're getting major blood treatments. They're getting major medications. The parents may be missing work as they're getting their child to and from doctor's appointments and hospitalizations. So getting them set up with social workers, helping them find alternative resources to help offset costs of things that make it less strainful. Or less of a strain. Excuse me, I just made up a new word. I apologize. Less strain on them. Caregiver role strain. Helping those parents cope. Maybe getting them respite care and talking with the nurses and the social workers to help set up time for respite when that child is in the hospital. Or helping them have time away to help their other children. Or when the child is hospitalized and siblings are at the hospital visiting, maybe getting our child life therapist or other people to come into the room and give those siblings attention, including everybody in the care, and just helping the family cope. I know we've talked about multiples of these things of ways to help the families in multiple classes, but that's just a little bit on sickle cell for you.